happening to this poor guy? Tyler, it's choice E, mesenteric ischemia. This is the blind spot drama. Evelyn and Arthur talk ophthalmology. Arthur: Yo, Evelyn, I just read a clinical vignette that is high-key nightmare fuel. This 65-year-old grandma rolls into the Che. He blind spot drama. Evelyn and Arthur talk ophthalmology. Arthur: Yo, Evelyn, I just read a clinical vignette that is high-key nightmare fuel. This 65-year-old grandma rolls into the emergency department because her left eye is completely acting up. Get this, she had cataract surgery with a shiny new lens put in 4 months ago. Everything was smooth sailing, zero drama, until this morning. She wakes up, looks around, and suddenly sees a literal dark web chilling in her side vision. Evelyn: a dark web? Like she is browsing the underground internet with her eyeball? Arthur: I know, right? Spider-Man vibes, but make it medical. And it gets weirder. Every single time she moves her left eye, she sees these crazy, blinding flashes of light. No eye pain, no hitting her face on anything, no headache, no fever. She is chilling otherwise. Evelyn: Oof. What does the doc see when they look into her eye? Is it looking cooked? Arthur: Her conjunctiva and cornea are totally clear, but her pupillary reflex to direct light is sluggish. Also, her side vision on the outside part, the temporal visual field, is completely tanked. Her right eye is vibing normally. So the question is asking for the diagnosis, and the options are honestly a trap. A. Central retinal artery occlusion, the ultimate eye stroke. B. Intraocular lens dislocation, the new lens just went rogue. C. Optic neuritis, brain wire inflammation. D. Panuveitis, the whole eye is on fire. E. Retinal detachment, the wallpaper peeling off the wall. Evelyn: Oh, people definitely fall for option B here because the writers dropped that juicy backstory about her cataract surgery 4 months ago. They want you to think the plastic lens slipped out of place. But that is fake news. The correct answer is absolutely E. Retinal detachment. Arthur: Wait, for real? Why is her retina just giving up on life? Evelyn: Think of the retina as the wallpaper at the back of your eye that catches all the light images. As people age, or especially after they have eye surgery like cataract extraction, the gel inside the eye, the vitreous, starts to shrink and pull away from the wallpaper. When it tugs on the retina, it causes mechanical sparks. The brain interprets those physical tugs as bright flashes of light. Arthur: So the flashes are just the eye gel being clingy and pulling the wallpaper down. Evelyn: Exactly. And when that gel officially tears the retina, fluid seeps right behind it, and the wallpaper starts peeling off completely. The dark web, or floaters she sees, are just pieces of debris floating in her eye gel. And that loss of side vision is because the peeling usually starts at the very edge of the eye before it hits the center. If it keeps peeling, she is going to lose her central vision too. Arthur: That is wild. Why not option B though? If my new bionic cataract lens fell out of place, wouldn't my vision go dark? Evelyn: If the lens dislocated, she would have blurry vision or double vision because the camera lens is crooked. But a loose lens doesn't create lightning flashes or a curtain-like dark web in your side vision. That is a pure retina problem. Arthur: True, true. What about option A, the eye stroke? Evelyn: Central retinal artery occlusion is a massive emergency where a clot blocks the blood supply, but that is a sudden, total blackout of central vision. No flashing lights, no warning floaters. Just instant darkness. Arthur: And options C and D. Evelyn: Optic neuritis and panuveitis are pure inflammation. They hurt. If your optic nerve is inflamed or the inside of your eye is on fire with uveitis, you will be screaming in pain, especially when you move your eye, and you will probably have a red eye or photophobia. Our grandma here is completely pain-free. She just has structural wallpaper failure. Arthur: Understood. Send her straight to the eye surgeon to get that wallpaper glued back down. High-yield breakdown symptoms and signs list sudden onset of a dark web or floaters in the peripheral vision. Photopsia, bright flashes of light triggered specifically by eye movement. Painless, monocular vision disturbance following a clear history of intraocular surgery 4 months prior. Sluggish pupillary reflex in the affected left eye, indicating impaired photoreceptor function. Temporal visual field defect, decreased peripheral vision in the left eye. The best giveaway clue: the combination of flashes of light, photopsia, with eye movement, and a new peripheral visual field defect, the dark web/curtain. Whenever a patient sees lightning flashes followed by a dark spot in their side vision, the retina is actively tearing or detaching. The trickery: the examiners explicitly mention her cataract surgery from 4 months ago to bait students into picking intraocular lens dislocation. This is a classic distractor. While cataract surgery, exam-oriented highlight lecture. Retinal detachment. Retinal detachment is a critical, sight-threatening condition characterized by the separation of the neurosensory retina from the underlying retinal pigment epithelium and choroid. On the USMLE Step 2, look for 3 classic risk factors: advanced age, severe myopia, nearsightedness, and a history of ocular trauma or recent intraocular surgery, like cataract extraction. The clinical progression follows a distinct path: posterior vitreous detachment, PVD. The vitreous gel liquefies and separates from the retina. As it mechanically pulls on the retinal tissue, it depolarizes the photoreceptors, causing photopsia, flashes of light. Vitreous hemorrhage/debris. Microscopic tears can release blood or cellular debris, perceived by the patient as floaters or a dark web. Regmatogenous detachment. Liquid vitreous passes through a retinal tear, lifting the retina off its bed. This presents as a painless, curtain-like visual field defect that classically starts in the periphery. Physical exam may reveal a sluggish pupil or a relative afferent pupillary defect, RAPD, depending on how much retinal surface area has detached. Ophthalmoscopy reveals an elevated, gray, wrinkled retina. Emergency ophthalmology consultation is mandatory for surgical intervention, e.g., pneumatic retinopexy or vitrectomy, to prevent irreversible central vision loss.